Neeraj, whenever you give the...
We are live. You can go ahead.
All right. Good afternoon. Welcome to the Association of Spinal Surgeons of India Master Series webinars. Today, the Master Series webinar has tough competition from the second T20 International between India and Australia. Australia set us a target of 194, and I'm sure we will all be excited to see what the outcome of this match is, but a little disappointed with their score. So I'm sure you all will want to come to this early onset scoliosis webinar rather than watching us lose today. So this webinar, early onset scoliosis, is a very, very complex problem. I think all of us understand this, and sometimes we feel, when will this, if a patient comes to us, we would rather have it go to a specialized center, because there are so many things to consider, so many problems that to overcome, and it is probably that requires a specialist to do this. Today we have exactly that. We have probably got one of the best faculty panels or pools that you can get. We've got Dr. Arvind Jayaswal, formerly from the All India Institute of Medical Sciences in New Delhi, now at the Primus Hospital, Professor S. Rajashekharan from the Ganga Hospital, Coimbatore, Dr. Arjun Dhawale from the Wadia and the Sir H.N. Hospital in Mumbai, Dr. Peter Newton from California in the United States, Dr. Jwalant Mehta from Birmingham, UK, and Dr. Suken Shah, who has visited us in India and taught us so much over so many years, and yet he continues to look so young and sprightly. So the early onset scoliosis seminar, I'm sure if you will give you a highlight or a decision-making algorithm about how to conduct this. And to conduct this webinar is none other than Dr. Bhavuk Garg, who is today the head of spine surgery at the All India Institute of Medical Sciences in New Delhi. Just to take you a bit on other activities of the ASSI, the next webinar coming up is a Pro Series webinar. This will be on the 10th of January, subaxial cervical trauma. And it will be moderated by Dr. Ankur Nanda from the Indian Spinal Injury Center in New Delhi. I would also remind all of you that this year, that is in the coming year 2021, ASSICON is going to be held on a virtual platform from 29th January to 31st January. The website is www.assicon2021virtual.com. The highlights of the meeting, we have an entire 3-hour session on the latest and the newest of spine surgery in a session titled Navigating into the Future. We have joint sessions of the ASSI with 2 leading spine societies across the world, German Spine Society and the Argentinian Spine Society. Besides this, we have got sessions purely on navigation in spine surgery, endoscopic spine surgery, post-operative imaging, improving outcomes in spinal surgery, and we've got masters of various spinal surgeries demonstrating their technique to us through specialized videos. We will also be having interactive case-based panel discussions. Just to give you a brief, the ASSI webinars which started during the time of lockdown, this is our 13th webinar. All these webinars are available on our YouTube channel, and you can watch them with the click of a button. You could also, if you don't remember this particular YouTube address, go to them through the ASSI website. ASSI Video Journal is an attempt to influence the practice of young spinal surgeons by giving them evidence to show how evidence influences your practice. And this time we have the 6th edition coming out on the 15th of December with Dr. P. Upendra from Bangalore talking about subaxial cervical pedicle screws and what is the literature that is available in the on the net which has influenced his decision making in terms of pedicle screw fixation. Also, ASSI has got a series of monographs which are available through the website of its publishers, TM, and on Amazon as well. These are a set of 8 monographs on lumbar disc herniation, stenosis, spinal tuberculosis, ankylosing spondylitis, early onset scoliosis, craniovertebral junctional anomalies, complications in spine surgery, and osteoporosis of the spine. I would encourage all youngsters to acquire these because these monographs highlight and look in great detail at all aspects of this particular topic. The ASSI textbook on spinal infections and trauma, which was edited by Dr. S. Rajashekharan, is available through Amazon and through our publishers, JMP Publishers. The Indian Spinal Journal, which is an official publication of the Association of Spinal Surgeons, with editor Dr. Anil Jain, is also launched and is a biannual affair. Right now, it is comes out twice a year, and you can access it online for free. The ASSI outreach program. ASSI wants to promote spine surgery in second tier and third tier cities across the country. And to do this, we hold a spine program in your town and try to help improve decision-making abilities of doctors, orthopedic surgeons, neurosurgeons, spinal surgeons, residents in your area. If you wish that ASSI should come to your town, please write to our secretary, Dr. Ajoy Shetty at ajoyshetty@gmail.com, and we will definitely try to work it out. The ASSI e-learning program is a feather in the cap of our president, Dr. HS Chhabra. It's an online spine education program curated by the Spine Masters and is available for free to all. I would encourage all of you to follow ASSI activities through our website, through our Facebook page, our Twitter handle, and the YouTube channel. And I'm sure you'll come to know all about our latest, newest activities and be abreast with all the work or all the work going on in spine surgery across the world. As far as this webinar and further webinars are concerned, if you have any doubts or queries, and if you can't, as we are streaming live right now on OrthoTV, YouTube, and Facebook, but if you can't get your queries answered through this, you can directly write to me or on WhatsApp. The number is 9820504351, and I'll be happy to put it through to the panelists of today's webinar. Thank you very much. And now, without much ado, let me call our moderator for the day, Dr. Bhavuk Garg, to come over and take over the session. Thank you very much, Bhavuk.
Thank you, Dr. Gautam, and I thank ASSI for giving me this privilege of moderating this webinar on early onset scoliosis. We have a galaxy of resonating personages in this field, and they are all mirific surgeons, and I will not dare to introduce them. They need no introduction. Early onset scoliosis as such is a challenging as well as an enigmatic issue in spinal deformities. Challenging because you have to strike a good balance between the deformity correction and the growth of the child, which has got a tremendous implications as such with respect to overall health of the child. And enigmatic because despite so many advances being made in this field, we are still searching for the optimal treatment. This webinar is going to overarch on practicalities of managing early onset scoliosis, strictly about what to do, when to do, how to do, and also about what, when, and how not to do. I wish we could have more time to cover the entire spectrum of EOS, but in view of time constraints, we have chosen 6 important aspects of EOS management. The first talk will be about the clinical and the radiological assessment by Dr. Jwalant Mehta from UK. Second, we have Dr. Suken Shah, who will discuss about the casting and the bracing. Third section will be on hemi-vertebrae, and it will be covered by Professor S. Rajashekharan. We are going to learn types of growth-friendly techniques from Professor Arvind Jayaswal. The technique, tips, and pearls of the growth rod application will be discussed by Dr. Arjun Dhawale. And finally, Dr. Peter Newton will discuss about the various protocols regarding the growing rod graduates. Since we have such an excellent faculty to gain maximum from their sagacious wisdom and experience, we have asked them only to prepare cases related to their talks to give some good learning points. We have some cases which we have prepared, and if time permits, we can discuss them in the end. So let me invite our first speaker, Dr. Jwalant Mehta from UK, to talk about the clinical and the radiological assessment in early onset scoliosis. Dr. Jwalant.
First up, I'd like to thank Bhavuk, Gautam, and the ASSI leadership for this opportunity. these are my disclosures. My charge today is to look at clinical radiological assessments of a child with early onset scoliosis, and we'd like to cover how we approach, what we should do, what we should not miss, and who else do we involve. First up, early onset scoliosis is scoliosis in anyone under the age of 10, irrespective of the etiology. This is just a very brief list of conditions. The breadth of the spectrum is much more than this, which highlights to us that we are covering a lot of ground in a short time that we need to assess when we have a child with scoliosis. To start with, there's a lot of useful background information. If you have someone with a prenatal history of a hemivertebra, the discussion with the family is usually one of reassurance, with something on the lines of "we'll see after the child is born and see you afterwards." The birth history, family history are useful. Age appropriate milestones are usually linked with the pediatricians because they are really good at that. But when we see a child further down the line, previous history of operations, especially GI and cardiac, are useful. General examination is usually with a child suitably undressed. Height, weight, arm span are very useful. Examination of the skin should involve looking for hairy patches, pits, any pigmentation, surgical scars, very useful. If you do find a pit, it's really important that you investigate it and not start injecting into it. A general assessment of the patient, including things like eye contact and how active they are, is a very good start point to knowing a little more about the child. Spinal examination, usually front and back, look at shoulder and waist asymmetry. Range of motion is useful. Trunk rotation is very useful. The scoliometer is largely replaced by the iPhone and the Android apps these days. Standing balance is not just with the person standing unsupported, but with suspension, which gives us a good idea of how supple the curves are, and which tend to be quite supple in the early childhood. Sitting balance is useful to know whether the upper limbs are used in the balance process or whether they are leaning despite the use of a brace and a wheelchair. Craniovertebral junction anomalies are very commonly associated. So look at the head tilt, look at any plagiocephaly, low hairline, short neck, etc. But also look at hand and foot weakness, which is can be a very subtle sign, as is nystagmus. Looking at a high thoracic curve in isolation or with a as a cause of the neck tilt is something that we see from time to time. Neurological assessment is extremely important. A very detailed assessment of motor sensory, particularly for levels in cases of dysraphism. Reflexes, you've got to keep in mind that deep tendon reflexes are monosynaptic. Superficial tend to be polysynaptic, the abdominal reflex, and are very, very useful. Planters and Babinski, particularly if they are asymmetric. Hand and foot size I've mentioned. Mental state, looking at the cranial nerves and gait analysis, as well as the cerebellar signs, is vital. The other important feature in the clinic to assess is how they are functioning, whether they are independent, whether they have any sphincter control, they can feed for themselves, they have a peg in place or not, what their self-care abilities are relevant to their age, and whether they have any systems in place at home or elsewhere, especially if they have severe body involvement. Ambulation status, again, this is pretty self-explanatory, although very, very useful information. Whether they are independent walkers, they need support, they need wheelchair adaptations, we need to help them with transfers, or they can bum shuffle. This is important not just to know what they are, but if we are going to operate, we need to make sure that we maintain at least that level of independence. Extremity assessment of the feet, of the lower limbs, of the upper limbs, looking at hyperlaxity, look at other conditions like Sprengel shoulder, very useful. Limb length assessment. Clinically, I rely a lot on the Gagliardi sign. Radiographic clues, looking at a full spine X-ray with the heights of the iliac crests are useful. But if you need a little more accurate information, then CT scanogram is the way forward. Radiographs, erect AP and lateral, usually for ambulant patients, or even the patients that can sit up, have the sitting X-rays, and in-brace radiographs for the braced patients. However, we just go for AP or only lateral for appropriate deformities for progression to check for alignment and progression. What's important with regards to radiographs is that the frequency is important and is a more of a judgment call based on the growth potential. There are various ways of assessing maturity, and looking at the Risser sign and the shoulder proximal humeral epiphysis is a very crude assessment, but for really young kids, there are more useful assessments that the radiologist can help us with. Having a good overview of the overall X-ray radiation through the whole journey is important. We have this a paper that has recently been accepted by the Bone Joint Journal, where we found that in under 10 years age, they had 13 times higher radiation exposure in the surgical group as compared to the non-surgical group. So it's really important to keep this in mind. Radiographic measures, although COB is a very convenient measure, it doesn't really help us a lot. And we've got to look at things like trunk height and thoracic height. So T1S1, T1, T12, but on the AP, but more important on the lateral. And these values have normative data. So we can look at that and we can assess where the child should be with regards the normal growth. A full spine MRI of the entire neuraxis, CV junction, look at tethered cord, midline defects, very useful, as also to looking at the discs in a lumbosacral spine. A CT scan is also very vital on various fronts, and really important to realize that we tend to do our CT and MRI under a GA, usually very early on in the treatment. We discuss it with the radiologists, have them reported, but also important to overlap this with any other imaging that may be required just to ensure that we minimize their GA. Vactral is a condition that we need to cover because this is when you see a person with a hemi-vertebra, you've got to consider all these other conditions. So you've got to think of doing things like cardiac echo, cardiac MRI, etc. And this really helps us in identifying and involving other specialties and doing other investigations. The problem of progression is very closely associated with the actual deformity, but more importantly with the thoracic asymmetry and lung function. Although a COB angle is a surrogate measure, we've talked about T1, T12, and T1S1, and it's really important to look at the pulmonary assessments as regards the history of chest infections, noisy breathing at rest, chest excursions. Marionetting sign is very important where the head is bobbing up and down, and that is a very useful clinical sign. But it's very important to identify that the lung function is usually done very, very well by the lung function colleagues, and they tend to have a variety of tools in their box. So it's really important to involve very early on pediatricians, pediatric pulmonologists, geneticists, radiologists, and it's really, really vital to assess these patients very carefully and identify colleagues very early on. So in summary, careful history, thorough evaluation, judicious use of scans, combined as required under general anesthetic, a cognizance of radiation exposure, and MR and a CT scan early on. Thank you.
Thank you,
now I've got a case that I can, or do you want to do any discussions?
Just a quick comment about the nutritional assessment in these pediatric childs. Sometimes they are very malnourished, and what's your indications and how you deal with them, and in what sort of patients do you go for feeding jejunostomy in these patients?
So as far as feeding jejunostomy is concerned, that decision is usually taken by the GI chaps. We don't really get involved. We get really actively involved, and I'll highlight this in my case that's coming up shortly. When we have a very thin child who's very slim for age and we are planning anything surgical, that's when we have a MDT and we have a nutritionalist and dietitians coming to that meeting where we pass on the care to them for a while. They can discuss with the family what they need to do, keep a tab on their weight and height, and optimize them. Once they are ready for the operation, they come back to us and say, yeah, you can go ahead, or that you have this very narrow time window that this is the best we can get them. And that liaison is really important because many of these kids are very slim, and if you're doing any posterior surgery on them, you have very prominent rods, etc., and that really is a limiting factor.
The another thing is like in congenital scoliosis, especially in early onset kids, it's very difficult sometimes to pick up the bars on the X-rays. So do you have any tips to identify bars, because sometimes they are left because of the lack of imagination, or sometimes they are actually seen because of as a figment of imagination. So what is your tip on picking up?
So the top tip for that is when you see anything on an X-ray that looks a little abnormal, get a CT done. A CT is the way forward to assess them, where you can do a 3D reformatting, and you don't need to do too many CTs. Just the one CT usually is enough, and discuss it with the radiologists, because they usually report these on high resolution screens. So irrespective of what kind of screens you have in your clinic, I would just pick up the phone and speak to them and just ask them, what they see and what they feel. Probably even go down and sit with them in their office and go through it. So that's really very important in assessing what we and discussing it with our colleagues as well as to how our treatment plan is.
Thank you, Dr. Jwalant. We can go ahead with your case now.
Is that my screen? That's not my screen. That's your screen. Can you share the screen with me, please? Stop screen share.
Are you seeing your screen? Yes.
Bhavuk, I think that's your screen.
No, this is yours one.
Okay, fine. Sorry. Okay. Thanks. So this is my case, okay? My disclosures. 3-year-old boy who came to us with a history of a dilated ascending aorta with the root replaced at childhood, mitral valve prolapse, right diaphragmatic eventration, undescended testes, again operated very early on in life, congenital hypothyroidism, foot deformities, he's had conservative treatment for his DDH, and he had genetic assessments before we saw him, and he had a diagnosis of early neonatal malformations. He also had bilateral congenital cataracts, high myopia. This is the X-ray that he presented with initially on the left-hand side. At the age of 3, he had. You can see that there are these clips from the wires from the time he had his heart surgery. We braced him because he had a very subtle deformity and he was not holding his trunk well. However, very early on, the family came back to us and said they were worried because when he wasn't wearing a brace, he was significantly off balance. And when we examined him and assessed him out of brace, in about 6 months' time, he was really going off in a big way. So we decided to investigate him further. And while we were getting our MR done, we saw that the curve was much bigger than it was early on. He also had a lot of early other factors. So he had a posterior fossa arachnoid cysts. He didn't have any other tethering further down, and his discs were fine. But when we did a CT scan, the curve was getting bigger each time we, assessed him or saw him. We did some reformats of the CT scan. There were no other conditions identifiable in the canal, and this is the condition we were left with. And by the time we got around to around 4 years of age, the curve had progressed considerably, so we really had very little time on our hands. He had a diaphragmatic eventration. So we discussed with the pediatric surgeons whether it's safe to go in from the front, especially on the left side. And prior to doing so, we did a traction X-ray under GA on him, and we found that he was still a bit flexible. So we decided not to do anything from the front. In Birmingham, we have a low threshold if it's a very stiff curve that we put in a growing rods after doing nucleectomy, annulotomy, just to create a little bit of flexibility. That's a non-fusion procedure. But when you have a traction X-ray that shows what it does, then we don't need to. So this is what we had. We then did sleep studies. We did respiratory assessments. The sleep studies were normal. We did a cardiac MR. We did a dietitian review, which unfortunately showed us that the child had a very low BMI, 9 centile. In fact, even without doing that, there was no rocket science in saying that he was very slim and he wouldn't have really taken much by way of implants. So here were our options: just a traditional, distraction-based traditional growing rods, anterior release and growing rods, magic rods, Sheila, or Vector. So Bhavuk, do you want to discuss this, or should I just show you what I have?
I think we can ask our faculty members. Maybe we can start with Suken. What's his choice?
Well, you're going to hear in the next talk that I try and delay surgical treatment for as long as possible. And so I understand that the deformity's progressed. He's got a sagittal plane deformity also that we have to consider to control. So here, if he has access to non-invasive lengthening methods, such as the magnetic rods, that would be our first choice, or some sort of passive lengthening system. If he's very frail, he's got some chances for complications related to the lengthening process, namely wound infection. So the traditional growing rods would be my second choice.
So my question is, like, in these sort of low BMI patients, the magnetic growth rod, the portion of the magnet is actually quite prominent, and it's actually, try to come out of the skin. Is it that a problem in the practice?
Well, that's what you have to anticipate with the placement. So you can use the various designs they have to hide the magnet, we call it, in a little bit more area where you have soft tissue coverage. Sometimes we're fighting with the opposite problem. Prader-Willi syndrome patients tend to gain weight as they age. And if the magnet is too far away from the skin, for instance, you have the opposite problem. So I think you have to plan for that. And we like to put the magnet in places where it will be less accessible or more accessible depending on the BMI of the child. So for instance, in this case, you may want to think about putting it away from the thoracolumbar junction, which is both kyphotic and prominent, and try and put the rod in the thoracic area or even the low lumbar area, the actuator, that is.
Okay. But that isn't the problem because the magnet portion is straight and we cannot bend it. And we are keeping it in thorax, which has to be in a little bit kyphosis. Isn't that a problem in the long term?
Sure. And so we have to anticipate that. We can contour the rod above or contour the rod below, depending on where. You can also even flip the magnet upside down and use it in a different format. So these are all very important considerations. And I would think outside the box sometimes. Just don't think of the only way to implant this device is in the standard configuration. You have to be creative sometimes, just as you mentioned.
Professor Rajashekharan, will you differ or your management remains the same?
Bhavuk, this is clearly not a very simple case. This guy has more complications and comorbidities as much as he has a complicated spine. So he's collapsing and progressing, but blessing is that he's very flexible. The traction shows very good correction. We don't use magnetic rods, so I would go in for traditional growth rods. Of course, where you're going to have your fixation points and other things, but those are technical points. But on the broad scale, growth rods for the moment.
So, Dr. Jwalant, I think most of us agree that we will go with the growth-friendly technique. Can you show us what did you do?
That's what we did. As Suken said, we've got to be a bit creative. So far, we've gone for a single rod construct. We've got the rod where it was least prominent. We have a good control of the thoracolumbar junction as well as the sagittal profile. We've had to go for a hybrid with the rib claw and two pedicle screws in the lumbar spine. Because he is very slim and we've had to use just the one rod, we are keeping a close watch on him. So now we've actually discussed him with the cardiac guys before that they would need to do as to whether they would need to do an MR or not. And they were pretty confident that they won't need to. So we've just hung fire with that for now. We've used the magic rod. Our current problem in the UK with the recent issues with the magic rod is that we've got to take special permission each time. We've got to change it or insert a new one. So when this guy comes up for his revision, we'll have to decide as to whether we go in for a new magic rod or we just go in for a more traditional. Whether we go in for a second rod, which is also rib based, or we convert it to a full spine based traditional growing rod is something we'll need. But for now, we should be able to just keep lengthening as much as we can for the next year or two, just to keep the spine length going. That's really the main crunch of this treatment.
Thank you, Dr. Jwalant. And now we move to the next talk by Dr. Suken regarding the casting and the bracing.
Great, thanks, Bhavuk. It's a pleasure to be here, and I wanted to thank the ASSI for this opportunity. So what we're going to talk about now are non-operative methods before our colleagues talk about operative methods, because these should always be considered before you move to operative treatment. I know operative treatment is very interesting, but we can really change the game if we can delay surgical treatment, and that's the point of non-operative treatment most of the time. So Jwalant did a great overview of how to do the workup of the child, but we have to remember that our goals are to control curve progression, optimize pulmonary function, spinal growth, and motion, and limit the number of complications. You'll hear in the subsequent talks that the surgical treatment is not well worked out yet in terms of limiting complications, and our focus is on trying to delay treatment whenever possible because we have to improve quality of life ultimately so we can get these kids to adulthood with near normal pulmonary function if possible. So casting has reemerged as a treatment for early onset scoliosis. Why? Well, basically, we know the morbidity of early fusion. We cannot do a fusion on a 6-year-old child and expect them to have normal pulmonary function by the time they're adults. That would actually cause thoracic insufficiency syndrome. So we moved on to growing rods, but you know that the complications of growing rods are quite extensive. Infection, rod breakage, anchor failure, PJK, and failure to achieve lengthening. And with every episode of lengthening, this risk factor increases. And I know that these articles will be gone over further, but that's what really caused the tipping point. The search for something better. And is this a definitive treatment or a delaying tactic? I would say in both cases that you might get either. Let's consider two important principles to decide whether to intervene at all or just observe. The rib vertebral angle difference described by Mehta has been a great prognostic indicator. Here you take the concave and convex angle of the apical vertebra and calculate the difference between those two angles. If that number is greater than 20 degrees, this will likely to progress and will not be likely to resolve. Another important apical vertebra relationship is the rib phase. If the apical rib vertebra is overlapping that pedicle, then that's considered phase 2, and that's more likely indicative of prognosis. So these are Mehta's recommendations for infantile idiopathic scoliosis. If the RVAD is low and the Cobb angle is small, this is likely to resolve. 80% of the time, if your RVAD is less than 20, that curve is likely to resolve. So do not initiate treatment, but observe the child at routine follow-up, and you'll look like a hero when the curve goes away. However, if the Cobb angle is greater than 30 degrees, the rib vertebral angle is greater than 20 difference, or the ribs are in phase 2, this is likely to progress. And I would advocate that you start early treatment in order to avoid further progression. So we can break this down, and non-operative treatment is observation for small curves, RVAD less than 20 degrees, ribs in phase 1, follow them until resolution. Also bring them back before the adolescent growth spurt to make sure there's no residual curve. However, if the RVAD is greater than 20, the curve is changing, you should initiate non-operative treatment with either bracing or casting. So we'll speak about casting because bracing is fairly straightforward. You're trying to do a custom brace, but the cast is applied with elongation, derotation, and flexion, proposed with the principles of Cottrell and Morel back in the 60s. Then we cut out anterior and posterior windows that allow the spine and ribs to derotate into those reliefs. This was popularized in North America by Dastu and Standers. And so although Mehta is credited with popularizing the technique and bringing it to North America, I think this article in particular shows us the technique. And obviously there are numerous videos that can show you that technique on YouTube now. But these are pictures from that article showing you the elongation technique and how to derotate the chest wall, ultimately cut out the windows. But this is the article that really started it all from the British JBJS. Mehta studied her lifetime experience, her career experience in infantile idiopathic scoliosis. 90 patients who were referred early resolved with casting. Some of those children referred late or had syndromes. Casting could not reverse the deformity, but just reduced it and was sort of a delaying tactic. So those are the key points. When you have a sturdy phenotype or a normal, what we call infantile idiopathic, they may resolve with casting, but some of these other more complicated children, it may just be a delaying tactic. There are some forces at play. We want to elongate the spine as well as derotate the chest wall. So here's a typical case where we're trying to figure out whether we should treat this patient at 12 months. They were sort of lost to follow-up. The deformity progressed quite rapidly. You can now see a 40-degree thoracic and 60-degree lumbar curve with that characteristic thoracolumbar kyphosis. In these children with low tone, make sure you look at that on the lateral. Here's the clinical appearance, and we did initiate casting in this child. And you can see that casting is pretty well tolerated. Now, I understand in India there are issues with climate and heat and taking care of the skin, but we really shouldn't dismiss casting as something just for colder climates. This is Mehta herself instructing our center on how to do proper casting. You can see that there's a chin strap and a mandibular holder, and then some traction on the pelvis to elongate the spine. This is done under general anesthesia. We then use padding underneath the arms and over the rib prominence and iliac crests. These are the 5 places where you're going to get most of your skin problems. And so you want to pad those areas with felt or Webril. We then apply the cast starting from bottom to top. We apply the translational and derotational molds, and then we cut out the anterior window. I don't use these lower rib holders anymore, like the mushroom shape. Now we just do a large oval. Seems to be a little bit better for the skin. And then we flip the child prone or sideways, and we do a posterior derotation window. This window is done on the concave side so that the ribs can fall into place. So this push is on the convexity. We're pushing forward, and we cut this window out on the back on the concavity to let the ribs fall into place. And then this is the finished cast with the trimming all around the skin areas. So here's a typical infantile kid. You notice the Cobb angle is larger. The RVAD is greater than 20. The ribs are in phase 2. We need to initiate treatment now rather than wait for this deformity to progress. So when you see the initial child with these parameters, you should initiate treatment now, either with bracing or with casting. But with early treatment in the proper child, these deformities can resolve. No further treatment was necessary after age 4. Here's another child with a larger angle, RVAD greater than 20, ribs in phase 2, with subsequent casting, again, the resolving treatment. And now they need observation all the way until adolescence, less frequently, but we still need to observe them through maturity. What about syndromic patients? This is a child with Prader-Willi syndrome. Fortunately, they have very lax ligaments. The curves are very flexible. We can elongate them very easily. However, resolution hasn't been the case in as many patients as infantiles. However, we do initiate casting in these children, and they do very well. This is an idiopathic infantile, same thing. What you want to look for in the initial cast is trying to resolve the RVAD. And you can see over time, we're not doing a great job of this. This child did switch over to brace treatment and is still currently in a brace. But with each subsequent X-ray, we'd like to get better and better correction of the Cobb angle, spinal length, and restore the RVAD or derotate the rib cage. The cast is, as I mentioned, very well tolerated in children. It does not cause a developmental delay, does not cause a delay in ambulation. However, there may be some other issues related to casting, which we'll get to in a moment. Overall, the results are quite good. We haven't yet been able to touch the results of Mehta's series, but Sanders and Dastu showed us that about 72% of children were able to avoid surgery. In many children, this was still a delaying tactic for later development. And you can see that further literature says pretty much the same thing. Delaying tactic, increase in thoracic height. And Arjun has a great paper in which we were able to illustrate that increased peak inspiratory pressure is a casting issue, and you need good anesthesia during this procedure to avoid a pulmonary problem. And so our newer data from the spine study groups illustrates that there is benefit in delaying surgery. You get lower complication rate in older children because they're more robust, better soft tissue. They can accommodate larger implants. They tend to gain weight, and there's a certain window of lengthening of time. And so we need to optimize that window and perhaps push that out until they're a little bit older. So who do we cast? We definitely cast idiopathic infantiles with that sturdy phenotype and a normal BMI. Some non-syndromic patients do the best. Definitely you want to see them when they're younger. So talk to your pediatric colleagues and other spine surgeons to refer these patients to a center early if they don't do casting themselves. Flexible, long curves with a low thoracic apex are probably the best because the cast can act during that in that location of the spine and delay surgical intervention. Who don't we cast? Well, this is a relative contraindication. Syndromic patients, maybe. If they're too old, they won't tolerate casting, and it's better to be in a brace. Curves that are too stiff can cause issues with skin and pulmonary problems when you're trying to mold the cast. But mainly, you want to avoid casting in restrictive lung disease states or patients who have issues with skin sensitivity, thoracic and abdominal wall contraindications, and anyone with a DVT risk. These are two articles showing you that casting can be effective both in Prader-Willi and our skeletal dysplasia patients. And so they should not be written off as patients who aren't eligible for casting. But beware of some of these conditions. These are syndromes associated with a small thorax and stiff curves. So if you put a constrictive cast on that patient, they're going to have some trouble. So be very careful with the initial casting. You may even want to admit that child overnight to prevent any problems from them going home and resulting in returning to the emergency department. What are some of the relative contraindications or absolute contraindications to casting? We don't cast children with osteogenesis imperfecta or metatropic dysplasia. They have chest wall deformation and very stiff curves in the metatropes with restrictive lung disease. So I would avoid casting those patients. Relatively, we don't typically cast children with cerebral palsy, spinal muscle atrophy, large chest wall defects or pectus carinatum, anyone with sleeping problems or reflex that can be aggravated by increasing intra-abdominal pressure. Definitely don't want to aggravate any cervical spine conditions with that traction device. And any child that has a lot of anxiety or claustrophobia should not be casted due to psychological issues. Generally, this is pretty well tolerated. Your biggest problem might be skin issues and skin breakdown. It doesn't cause developmental delay. However, in children with significant muscle weakness, such as spinal muscle atrophy, it may provide some issues with ambulation, joint pain, stiffness. Sometimes children have trouble sleeping in the initial phase, but generally they can get over that. Again, tell your anesthesia colleagues this is not just a benign procedure for the lower level resident. The attending needs to be in the room for that part where the cast is applied, curing, getting hard, before the abdominal window is cut out. Then those pressures will slowly return to normal. Anybody with a DVT, there have been case reports of subclavian vein thrombosis and other issues related to casting, and anyone with acute asthma or previous history of respiratory arrest should be avoided. But then sometimes when you talk to these parents, they're generally well accepted of casting. But this mom told me about toilet training issues that she had with her cast because some of the issues where the cast got in the way. But you can anticipate some of these problems, and parents are very willing to go through this treatment because they know it can be beneficial in the long term. Those factors related specifically to response to treatment seem to be characteristics about the patient's diagnosis. Their BMI should be near or less normal. Avoid casting in the very, very frail child who may get skin issues and who's too old. So younger children, normal phenotype, good BMI, and then try to get that derotation off the first cast, the RVAD less than 20. But definitely, the smaller you make the Cobb angle, the better you make the RVAD, the better response to treatment in a cast. Sometimes we convert to bracing or start bracing initially. This should be a custom brace. I'm showing you two examples here. Large belly window cutout, just like the cast. Small children breathe with their belly. They need to have a large belly window cut out. You need to be able to examine the skin at frequent intervals. And with a bracing, I would go for 22, 23 hours a day in some of these children, just like a cast, but can be removed for bathing or certain physical activities. Sometimes we even use a cast holiday during the summertime in the US to allow them to have some time at the beach or the pool and convert to a brace. I know this is controversial, but kids need to be kids, and the family sometimes needs a break. What about congenital scoliosis? There are some studies that in congenitals casting can be useful. I wouldn't consider it the primary treatment, except for those compensatory curves that you're trying to balance the spine and delay a further operative intervention. So based on the current evidence and these review articles, I would say that a trial of casting for early onset scoliosis should be considered in every children, describing this as a treatment option. But remember some of those other conditions that may be aggravated by casting. What are the areas of controversy or equipoise? Well, there's certainly, there's clinical uncertainty about treatment options. When to cast, when to brace. I would cast the younger children and maybe use a brace in the older children. But you can use this COS classification as to when to switch from casting to operative treatment. When should you stop casting and move to surgery? I think some of our other speakers are definitely going to talk about surgery. But when the curve is progressing despite casting, or the treatment is causing more problems than the scoliosis itself, I would tend to look at then moving to operative treatment. But typically by convention, we say 6 years old, 60-degree curve may be more eligible for operative treatment because then we can move that window out until they're a little bit older. This is a nice slide from Mehta showing us that children are like wildflowers. Some just need to be watched, and some others need a little bit of encouragement and growth guidance in the beginning. So thank you very much. We can move on to the next speaker because I showed some cases during the talk itself.
Thank you, Dr. Suken. I have some questions. What's your protocol of changing these casts? How frequently do you change, and do you put the patients on brace in between the casting, and how do you manage your cases routinely?
Well, there's a lot of variability there, but I would say in general, the younger children need more frequent cast changes. You'll see in the literature, this is anywhere from 6 to 12 weeks. I don't do 6-week cast changes. We try to push this out for 3 to 4 month intervals, even in the youngest children. One thing we have to remember is the risk of cumulative effect of anesthesia, longer anesthetic times, more frequent exposure to anesthesia is maybe just as bad as radiation. I mean, different side effects to the developing brain. But when we do it under general anesthesia, I try to do it every 3 to 4 months. I don't use a brace between casts, except when we've done about a year worth of casting. The spine is very straight. 15 degrees is our number to perhaps consider switching to a brace for either a holiday or switching to a brace and following that child over time.
Since you have talked about the issues of general anesthesia in pediatric age group, now there are some papers which are talking about the awake casting. So
yeah.
What do you think?
I think in a cooperative child and a cooperative family, you can do awake casting. Some parents are using an iPad or having the child watch a movie. I think if it's their 6th, 8th, 10th cast and the kid is cooperative, you've met some 3 or 4 year olds who are quite mature and cooperative, you can do that. It has to be customized for the particular child and the family. It shouldn't be the first cast, and it shouldn't be, a 12-month-old that just can't hold still. I think you get a much better quality, effective cast when the child's asleep. And then later, you can consider switching to that awake technique.
Bhavuk, can I just ask a question to Suken? Suken, great talk. What is the oldest age that you have casted a child? That's number one. And then some of these children have some pelvic imbalance. To them, have you had a modification of extending the cast to the thigh? Is that a possibility?
Yeah, great questions, Raja. So we've casted children up to 6. I would say that most of the time they're going to be syndromic children where we're just trying to delay treatment for a little bit longer. But typically we stop casting probably around 2, 3, 4 years old, depending on the duration of casting when we started, and then switch to a brace. I'll tell you, we've seen on the quality of life questionnaires an improvement in quality of life when switching from casting to bracing. So obviously there's a family benefit in getting out of that cast into a brace as soon as possible. And with regard to the pelvic obliquity, you can apply a trochanteric pad and you can extend the cast a little bit distally to control that. But then you have to remember, you're going to probably introduce issues with potty training, with sitting, and sometimes even with ambulation. And so that risk benefit needs to be considered.
All right, thank you.
Do you use neuromonitoring while applying these casts?
No, we don't. Typically, they're under general anesthesia, and since we're only applying gentle traction to the cervical spine, we don't anticipate there's going to be any neurologic deficit. I haven't seen a case report with that being done with casting. Sometimes if the cast is too high underneath the arms, you might get a temporary brachial plexopathy, but by then the child's awake. That takes some time to develop, and then you can easily treat that. But I'm not aware of any neurologic deficit secondary to casting. Because it's under passive stretch and it's an external issue and not an internal distraction, I think you're safer off.
Thank you, Suken. Now we move to Professor Rajashekharan regarding the management of hemi-vertebrae.
Right. Thank you, Bhavuk. This is a great opportunity to be with all of you. So hemi-vertebra is the most common cause of congenital scoliosis. And the most important thing for younger surgeons and trainees to note is that it's both a coronal and sagittal plane deformity. And sometimes when the hemi-vertebra is placed more posterolaterally, the kyphotic problem can be much worse than the scoliotic problem. Now the topic is hemi-vertebrectomy. So the first question is, who requires surgery? And an understanding of the natural history and the rate of progression is very essential for us to know about this. Why is it so? Because these kinds of complications should not happen. Now, this was a child which met the surgeon, and unfortunately, an advice was given that probably the surgery can be delayed till the growth is complete. And look at this, after 8 years later, the deformity is much, much worse. And this kind of procrastination should never occur. So we have to make a good mathematics of which are all the possible curves which are going to progress. And in this, we need to look at what is the type of hemivertebra that we are facing. Now, of the many types, the unilateral unsegmented bar and having a contralateral hemivertebra is the worst that can happen. And that has the highest level of progression. Next in line is the unilateral unsegmented bar. Double unilateral fully segmented hemivertebra comes next. Single fully segmented hemivertebra. These are the 4 types which usually progress over here. So if you have a vertebra like this, you can see that this has progressed from 20 to 45 because this has a growth plate at both ends, a full disc over here, and then they progress quite a lot. Now, McMaster's rate of progression, and this table is a very good guideline to follow. Block vertebra and wedge vertebra very, very rarely need surgery. Double hemivertebras are frequently requiring surgery, whereas a unilateral unsegmented bar and a unilateral unsegmented bar with a contralateral hemivertebra, they always invariably require surgery and they need good supervision because these cases can increase by 10 degrees every year. Now, the other factors which will guide us into surgery earlier is actually the location and also the number of vertebrae. Now, lower thoracic and thoracolumbar junction has the highest rate of progression. I'll show 2 examples. And if you have 2 hemivertebras, either closely placed or just with 1 or 2 normal segments in between, they also tend to progress quite a lot. Now, if you have a younger age and with many more years of growth to happen, now these are also the patients who need careful follow-up and surgical intervention at the time. Junctional hemivertebra are always very important. Now, if you have a vertebra at the lumbosacral junction, then you have the whole body tilting to one side, and these must be addressed much earlier. And similarly, hemivertebras at the cervicothoracic junction also produce deformities and then that need surgical addressing much earlier. Now, evaluation has been dealt with Jwalant. I would like to re-emphasize that all these cases require CT scan and MRI. Now, CT scan, especially to find out fused lamina and a bar which can be present, which is not very obvious in the radiographs. And MRI is an absolute must for delineating the neuroaxial abnormalities and what is the growth plate status. Now, this is very important. I think Bhavuk actually initially asked us, set off this question to Jwalant. How do you try to find out whether there is a bar? And it usually sometimes requires a CT scan. You can see there is a complex radiological abnormality over here. But when you look at the CT, and here you have to have cuts from anterior to posterior because the bar may not be very obvious in some of these cuts. But as you go on to the posterior aspect, you can see here that these are the hemivertebra, but there is a bar over here. And knowing this is very important because in surgery, you can go for it and you can see that there is a huge bar placed posterolaterally. Now, why you need this? Because you need to actually go and make a good preoperative planning on how we are going to excise the bar and how we are going to correct it. The location of the vertebra, hemivertebra, is also very important. And thoracolumbar junctional hemivertebras are notorious for progress in kyphosis rather than in scoliosis. Here you can see that when you look at the AP view, it doesn't look bad at all, but there is a tremendous kyphosis. And if you leave them even for a few years, the progression can be very huge and sometimes you can end up with neurological deficit. Typical incarcerated vertebrae where they are posteriorly placed and these actually also retropulse. And if you can see here, they also cause a discontinuity of the posterior column over here, what we call as the spine at rest sign, and that leads to actual progress in deformity. A good example, 33 degrees, 51 degrees, and a sudden progress to 104 degrees. Now, if you actually look at why is this sudden progress within 1.5 years, you can see that the facets actually start dislocating on the posterior side. Once the facets dislocate, they also translate anteriorly. and the progress becomes very fast. And so when you're looking at a junctional, especially at the thoracolumbar junction with kyphosis, please watch for the facet status as you are. We have to look at the neuroaxis abnormalities, the tethered cord and spinal dysraphism especially, and also the vectoral syndrome. Together, in most of the cases that require surgery, they can occupy up to 40%, and sometimes they need to be addressed much before. A good clinical examination for dermal markers and for other radiological abnormalities is very important. What is the role of bracing? In hemivertebra, you don't cast, but there is a huge role for bracing. Whenever the child has got a balanced spine, it's not too offset, and to prevent secondary curves to form. And as you wait for the child to grow up, now there is a very good role for bracing. When you need to do and come to the stage of surgery, the two major options are to do an in situ fusion or a convex hemiepithelial disease, or to actually do a hemi-vertebrectomy. Now, whenever you have a complex case like this, where there is a cervicothoracic junctional anomaly, multiple hemivertebras, a bar where you are not very sure of your surgical results, early on, you can do a convex epiphyseal disease. And this will offset the progress, which otherwise would follow. And you can see on this patient in 4 years, he is just holding up very nicely. And this is a much simpler surgery to do than to do a very complex multiple hemivertebrectomy at that sensitive area. When you want to do a hemivertebra excision, that's a very good surgery and much less complicated than the other EOS surgeries. Now, this was actually described as early as in 1928. And there was, for a short time, a controversy between an anterior surgery and posterior surgery. But now most of us would actually do all the surgeries from the posterior side. The modern dictum of that the front door to the spine is actually through the back is also over here. Now you would operate yearly, and that's the reason you need to know the natural history of the patient whom you are seeing. If you have a double hemivertebra, or if you have an unsegmented bar with a contralateral hemivertebra, we actually tend to operate as early as 2 years or even 3 years. And pedicle screws can be used safely, as was shown by Harms. And we have also published before that pedicle screws in very early age is quite amenable. Why you need to operate early? Because when you are tackling the curves when they are very young, when they are very flexible, when no secondary deformities are there, you can very much limit the segments that you are actually need to fuse. But as you go to elderly children and stiff curves, then you sometimes need to go 2 to 3 segments above and below, and this can be prevented if you are operating early. Now, if you get into stiff curves with also very severe kyphosis, then the surgery itself becomes very big. And also when you are going for curves which are at the junctional levels, again, you need complex fixations. So if you have a curve and you know for sure by the natural history that this curve is something that will tend to get worse, get into the surgery early rather than late. Now the surgical technique, I'll be showing a short video, but also the principles, exposure of only levels to be fused, because in children there is autofusion wherever you expose. You always place your screws superiorly and inferiorly. And the lamina are sometimes posteriorly fused, and you have to carefully excise them. And once you delineate the margins of the dura and the nerve root that is coming out, then you can do a pediculectomy, then expose the hemivertebra. Make sure by good diathermy dissection and also by pushing in some gauze piece or a pusher. The cleavage plane in children on the lateral side of the vertebra is very good. And then you put a dissector over there to protect the vessels. And then more importantly, you have to take away the disc quite above and below well. And what is important is, apart from concentrating on excision of the vertebra, you also need to concentrate on releasing the concave side. And most of the time, the problem of having an insufficient correction is because the release on the concave side has not been done. So once this is done, then you cancellate the bone, or you excise the vertebra in one piece, and then you can put your pedicle screws and rods. You can compress on the convex side, and then depending upon what is the surgery that you are done, you can either add a bone graft here, or you can keep a cage which you can use as a fulcrum, and then you get a good correction. Now, just a short video to just show the presentations. This is a 3-year-old child, and you can see that this child had 2 hemivertebrae closely placed to each other. So one hemivertebra with 2 good disc spaces on either side at L3, and another one at T12. Both of these are full hemivertebrae, and surely the potential for increase is very high, as you can see over here. 52 degrees at diagnosis, braced for some time, was holding up at 50 degrees. But then you can see between March 2019 to within 16 months, it has increased to Olympus 86 degrees, which means that this is a time that you need to get into and operate. So operating early would also allow you to save the segments, because from here at this stage, it is possible to do a hemi-vertebrectomy, double hemi-vertebrectomy, and we can limit our fixation to T9 to L4. Now, as I told you, there should be adequate exposure, but we will also expose only to the levels that are required. Once when the pedicle screws have been placed, either by freehand or by navigation, you first do the release on the concave side. That's very important. So you do a full release on the concave side, then do a meticulous laminectomy over here. Sometimes this lamina is fused with the other lamina. So you do a good laminectomy, and then with a good diathermy dissection, you delineate the extents and margins of the hemivertebra. So that is the transverse process, and that is the foramen over here. Now, once you have delineated the vertebra, you can then do excision of the posterior segments. There might be some bleeding when you're coming on to the lateral aspect, close to the dura. You have to be careful that you're not injuring the epidural vessels over there. If there is a bleeding, then you control it with Surgeries. If you have ultrasound cutter, Masonic, then we use it to remove the bone posterolaterally. So you always have the cord under your vision, making sure that it is safe. Now, once you are removing the pedicle and you have the bone flushed over there, then you concentrate on the proximal and the distal disc spaces. Protect the cord either by using osteotome or by curates. You completely evacuate, take away the disc. The hemivertebra is completely excised. There might be some bleeding at the stage, which can be usually controlled by cautery and also flow seal if you require, or some packing with Surgeries. And you do the same procedure to the upper hemivertebra. You must have a good rod fixation on the opposite side, because in small children, the whole spine is very mobile during the whole process. And once these 2 vertebrae are excised, it is your choice whether you place a cage. There is a need for a cage, which we use in a little more elderly children, or if you are able to approximate the vertebra well, we just pack it up with a good amount of cancellous bones that we have removed. So here you can see that a curve of 86 degrees with double hemivertebra has been nicely corrected to almost good sagittal and coronal plane alignment. So we give a spica sometimes for 3 months if the children are very small, and followed by a brace. Now, these are all the principles of surgery, which we have already alluded. I just wanted to put on this because to show that in little elderly age, children, we use a cage often. And we have found that getting an anterior fusion is paramount importance to prevent an implant failure at a later stage. So the last slide, the complications can be excessive bleeding, but this can be avoided by good surgical technique, packing up the epidural wells and protecting them with Surgicel or using bipolar coagulation or flow seal. You must be careful to avoid dural tear. Neural deficit in this type of surgeries is very, very rare, extremely rare. You have to always expose the dura and keep a good watch on what you're doing. And when you are compressing, you must make sure that, especially if you are correcting a kyphosis, that you have done adequate laminectomy above and below so that the lamina is not compressing on the dura. Pseudoarthrosis you avoid by adding adequate amount of grafts and also a cage when necessary, and make sure that you have fixed adequate levels so that there is no progression of secondary curves. So thank you very much for this opportunity. Thank you.
Thank you, Raja sir, for such a comprehensive coverage of hemivertebrae. Just a quick this thing. Sometimes, you know, in the post-operative X-rays of hemivertebral excision, we see a little bit remaining the coronal or the sagittal malalignment, like we see in AIS. You know, if we are going for selective thoracic fusion. Yeah. So, what's the long-term outcome of these things? Do they correct themselves or do they progress?
So. Most of the time, this problem happens because we are fusing too less a segment. I mean, if preoperatively this curve already has some amount of secondary curves, or you find that in your traction films or bending films that there are a few more segments added on to the curve, which is not completely correcting. If you don't include those segments in your primary fixation, then you find that they are slightly different. If it is only a mild decompensation, we have had many now cases which get corrected spontaneously with some bracing for some time. So you don't need to panic if you see a little bit. You need to reassure the parents and follow them with the brace. And most of them show spontaneous correction over a period of time.
Raja, this is Gautam here. There are some questions which have come from the audience. The first is addressed to you, so I'll just put it through. And that is, how do you decide between a hemi-vertebrectomy and a curve correction? Because sometimes by the time you get, like in the curve you showed, there was a significant scoliosis which had developed. So how do you decide that vertebrectomy is going to be enough? Because this child is going to grow, maybe the curve will again recur over a period of time, even if after you have done a hemi-vertebrectomy.
Yeah. So Gautam, the answer is the same as I alluded in the talk. So you need to make a preoperative judgment by looking at the flexibility of the curve, the extent of the curve, and what is the remaining segments that are included in the curve in your bending films and traction films. Now, let's suppose that the hemivertebra is a L1. In a bending film or traction film, that you find that it corrects very well. There is a sharp angulation, but there are no secondary curves included. Then this is a perfectly suited curve for a hemi-vertebrectomy. But if you have an established secondary curve which is not fully correcting on your bending films, then some amount of stiffness has developed in the secondary curves. And if you don't include those segments, then definitely you will have a poor result.
The second question again from the audience is the problem, is there a problem of crankshaft in these patients after you have corrected the deformity?
Okay, that depends. See, crankshaft is going to happen when you have fused posteriorly and there is a number of segments which are continuing to grow anteriorly. It is not going to happen when you do a hemi-vertebrectomy and you just fuse one or two segments before. So I don't think crankshaft is a problem when you do a hemi-vertebrectomy. It is a problem probably when you are doing a multiple segment fixation as in EOS or in early juvenile idiopathic scoliosis, where for many segments you have fused posteriorly, but the segments will continue to grow anteriorly. In a single or two segments or three segment fixation, as you do in hemi-vertebrectomy, I don't think there is a problem of crankshaft.
Right. Thank you, Raja. There are a couple of questions which have come for Suken. Can I put them through at this?
Please, sure.
Suken, the questions from the audience are, when do you decide bracing has worked and now we can stop bracing? Second question is, do all casts, I mean bracing, like casting has worked and it can be stopped. Do all cast stoppages end with bracing, or you can just completely let off any form of immobilization externally? And the third question to you was, what are your criteria for surgery, because casting has not worked in this particular child?
Okay. Well, we'll take the first one where when do we decide bracing or casting has worked? I think a curve less than 15 degrees will switch from a cast to a brace. And then just as in AIS, as we slowly wean the brace, if the deformity correction has been well maintained out of the brace with a standing x-ray when the child's a little bit older, then we'll start to decrease the wear time of the brace from 22 hours to 16 hours to nighttime bracing only. But what's key is I've seen some deformities recur at peak height velocity. So a child who was treated in a brace up to age 6, we may follow yearly or every other year, only to have an issue happen later when the child is 10 or 11 years old. During that explosive growth phase, you may see part of the scoliosis recur. So long-term follow-up is very important. All cast stoppages don't have to end with a brace. If the child has good core strength and you're seeing an out of cast or a standing x-ray show that there's full deformity resolution, then we don't have to use a brace all the time. And as a rule of thumb, I don't like to do growing rod instrumentation prior to age 6 or 7 if we can at all help it. And so the casting will probably switch over to operative treatment when we cannot control the deformity in a cast any longer. There's skin issues or other psychological trauma is too much to bear for the child, or the child is now old enough and appropriate enough for growing rod instrumentation at around age 6 or 7.
Right. What is your criteria for deciding that this much is the curve that I will be able to correct very easily with a growing rod, and therefore I can let the, even if the curve is progressing a little bit, I'll just wait up till it is 60 degrees or 70 degrees. How do you decide that?
That's based on flexibility and location of the curve and also the sagittal plane, provided that there's no neurodeficit developing, obviously, which will only be an issue in congenital curves. But with a typical curve, we will kind of prolong things as long as possible, provided the deformity is flexible. If the deformity is progressing and it's getting stiff and it's really developing sort of a malignant rotation, I think those apices are very difficult to handle with typical growing rod instrumentation. And so we'll intervene before that's a problem. So, our results from growing rods have been very good, but it's probably because I like to intervene before the deformity is too out of control.
Right, thank you. I think Bhavuk, back to you.
Yeah. So now we move to the surgical part, basically the typical for the early onset scoliosis. Professor Jayaswal for covering the growth-friendly techniques of early onset scoliosis.
Okay. Thank you, Bhavuk. Am I audible? Bhavuk, can you hear me?
Yes, sir. Yes, sir.
Okay. So, as Suken rightly pointed out, first when you initiate treatment, you need to
share your screen, sir. You need to share. You need to share your screen.
My screen is not getting shared. Okay. So what do I do now? This is there.
It's a private screen.
Share. Okay. Now, can you see that now?
Yes, sir.
Okay. Right. Sorry about that. So as Suken rightly said, you initiate your treatment in these young kids with casting or bracing. We tend to do an alternate casting and bracing as such in very small children. And we start with an GA, then go on to non-anesthesia bracer casting. And we tend to do 2-3 castings during winters and then switch over to bracing in summertime. But even in the best of circumstances, a lot of these patients really they just go off. And when they progress, then you don't have an option. So when you land up with a severe deformity and a truncal shift in these kids, then you are looking at a surgical option. Now, it has all been worked out very nicely in adolescent, mature spines that, instrumentations and fusion control your deformity. But in kids, that is a big problem. Fusion is not a good solution, and you are aware of it. If there's a local defect, if there's a focal defect, 1 or 2 vertebrae involved, then as Raja rightly pointed out, you can do a vertebrectomy or decancellation, instrument and fuse it, and they would do well, correct well, as in a congenital hemi-vertebrectomy. But it's been worked out, but if the involvement of the vertebrae or the segment is more than 5 in an immature spine, then fusion is not a good option because, as you all know, there is a question of not only the deformity keeping under control, but the growth comes into effect, the spine growth as well as chest wall growth comes into effect, and hence the development of the lungs, and which may lead to thoracic insufficiency and even mortality as such. So when we are looking at the surgical aspect of EOS, we have to be a balance between the control of the spinal deformity and enhancing and continuing the truncal growth and chest wall expansion as such. So definitive fusion in EOS has given rise to what is now called fusion-less surgery with growth-friendly devices. Now, looking at the evolution, the first fusion-less procedure was perhaps a subcutaneous Harrington rod. An unstable fixation, the anchors were poor, but was bound to fail, it failed. Then came the Luke trolley, and more stable, but led to premature spontaneous fusion given up. What stabilized in the management strategies in EOS were growing rods, starting with single rod and then going to dual rod techniques. In between, vectors came in, and then Sheila procedure made an entry. I will talk about these later on. Anterior fixation, anterior growth modulation was being experimented with the shape memory alloys and given up. Tethers has again made an emergence with good anchoring devices and a good cable, and anterior vertebral tethering is now making a foothold in the management of EOS as such. And we'll talk about it later. So if you're looking at the classification of growth-friendly systems, they can be classified as a distraction-based systems in which we have the growing rods, conventional and magnetic, or vector. In compression-based systems, you have the vertebral staples and tethers. Guided growth systems are Sheila and Duquet trolley, and you can have a combination of some and hybrid modification of that. So as of now, the mainstay of treatment and management in EOS are dual growing rods. And where you have fusion at the 2 ends of the curve, and you pass a subcutaneous or a subfacial rod and anchor it in, and then connect it through these connectors, in which case you just open serially every 6 months and do a distraction just using an opening in the region of the connectors as such. How often do you distract? It has been worked out to be about six distractions. You do a distraction every 6 months, about twice a year. If you distract more frequently, it will be more physiological, but then repeated anesthesia and multiple surgeries is a problem. If you distract too late, that means beyond 1 year, then spontaneous fusion occurs, and then it doesn't work too well. How much do you distract? About 0.5 to 1 centimeter in a conventional distraction rod every 6 months to match up with the growing of the spine, growing length of the spine. We tend to use the lateral connectors because these are smaller. Then when you expose them, you have a small exposure during lengthening. Also, you have space above and below to contour your rods to the spine. And that's a big benefit in using these lateral small connectors as such. You go in every 6 months, do a small exposure, and then distract, as I said, 0.5 to 1 centimeters a year per every distraction as such. And basically, these growing rods act as internal braces, and you keep distracting them so that the lengthening of the elongation of the system occurs to keep pace with the elongating spine as such. And so then you're able to carry the deformed child in a more balanced environment and carry them over with multiple distractions to when they're around 10 years of age. And then you finally do a final fusion in that balanced spine. The growing spine study group has recommended that when the research is more than 2, or when the age of the patient is 10 to 12 years. Why when the 10 years old? Because DiMaggio's concept that about at 10 years of age, the spine growth 80% has been completed. So you can go ahead and do a definitive fusion. Or if there's infection in between and you do have to have a revision, then you have to do a fusion. Or in case when you're not able to distract anymore, then you go ahead and do a final fusion. But when you look at the statistics, these are fusion-less techniques, and majority of the spine is growing and fusion-less. So there are large number of implant failures and reported incidents between 20 to 30% in almost all of the series, including the rod breakages, the anchor failures, whether you're using hook or screws. But the important concept here is, an argument given is, that when you're distracting them in a traditional growing rod every 6 months, that is the time when you tackle these implant failures. And so you're able to sort of get rid of this. Now, as was done in this particular case of 5-year-old congenital thoracic scoliosis, we had a screw failure on top, and during one of the distractions, the screw was changed, and then we were able to carry the child further on. Now, we had looked at our series in a multicentric trial, 48 patients, and the complications besides implant failure were infections and neural deficits as well. So there were 246 surgeries in 48 patients, but then after index surgery, the unplanned surgeries were about 38%. And we looked at it, and if you do your surgeries in patients less than 5 years of age, then your unplanned surgery rate goes up. Similarly, in syndromic, the unplanned surgery rates goes up, the complications go up as compared to neuromuscular, congenital, and idiopathic. Besides, in a conventional growing rod, because of multiple surgeries, there are problems of wound complication and scarring. Also, multiple surgeries, multiple anesthesias give poor psychological outcome. To circumvent all this, the magnetically controlled growing rod systems evolved. These are titanium rods with an enlarged mid portion containing a magnetically drivable lengthening mechanism. So you don't have to go in every 6 months, open up and distract. You can just bring an externally applied magnet remote control, and in an outpatient without intervention, you can lengthen these rods. And then you can do a multiple distraction at intervals of 6 to 8 weeks, which are physiologically more compatible with the spine growth. And at each distraction, it is worked out, you distract about 2 to 5 millimeters. You have dual rods there. So you can distract them disproportionately more on the concave side and on the convex side, you can work it out. Now, the amount of distractions that you can do can be looked at radiologically by these markings here. The yellow markings is where the distraction of the rod really occurs at the ends. Now, because of the effect of radiological hazards that you will be subjecting to a young patient, we are now looking at the growth occurring in these magnetic rods by ultrasound procedures, where you can measure the amount of lengthening that is achieved. So in this child, it was carried on to about 8 years old, an 8 years old congenital right thoracic scoliosis, premenarchal, and you can see the 2/3 of the thoracic spine is involved. We decided to do a magnetic rod, and we carried the child over to 13 years of age, and you can see that the growth of the child has been very fairly decent. She's almost the height of a mother at 13 years of age. And if you look at the radiological finding, the crowded ribs opened out with a serial distraction, giving enough space for the lung to expand as such. And then 16 years, the child has grown to beyond the height of her mother. So it does work, but there are limitations in magnetic growing rods also. And that is because at the level of the magnet, you cannot bend that area. So you cannot contour the rod as much as you would in a conventional rod with the lateral connectors. So that's the major disadvantage, and almost always lands it with a flat back, especially if large segments are being spanned as such. The cost is another major factor in these children. And in young children, if you start using magnetic rods, then you may require to exchange the rod before skeletal maturity. And that is itself is a big expense, because the distraction space in the magnetic rod is limited to about 48 millimeters. So once you've reached that distraction and the length, then you need to sort of change it over. Then some other growth-friendly devices, one of them which was tried and was talked about were in a big way, came with a bang, were vectors. The vector expandable prosthetic titanium is very expensive, but where you'd have proximal anchors in the rib, and the distal angles could be in the rib. So you have the rib-to-rib distraction or a rib-to-vertebral distraction as such. So you can have a combination of it. This was modified, and now we would do a rib spinal distraction. Once had it worked with a larger number, and it did distract the chest wall as well as the spine. It's also in multiple congenital abnormalities to some certain extent. But there were a lot of complications here. See, the breakdown, the scarring, the stiff chest wall led to giving up of vector by most of the centers as such. Sheila procedure was another very interesting development in the growth-friendly devices, introduced by Rick McCarthy, which involves apical fusion. So here the apex was targeted, fused, and the ends were then allowed to grow in a guided manner through these unlocked screws. And the rod was then allowed to glide spontaneously as the growth happens. So there was no necessity of repeated surgeries for distraction as such. So the difference between a growing rod and a Sheila technique is, in Sheila you target the apex, you fuse the apex, and the ends, the screws are not locked in, so the ends are allowed to grow in and keep the ends are the rod is left here, and then they are allowed to grow in, as compared to the growing rods where the apex is allowed to grow and the ends are fused as such. So when you leave a length of rod on both sides over a period of time, with the spinal growth, the rods become shorter, and that is evidence that this growth is being accommodated. And sometimes you need to go in and change the rod. They change the rods as such. So as compared to growth rods, the reoperation rate in Sheila comes down drastically, but it has been shown that unplanned surgery rates go up, and you're not getting any major benefit in implant complications or in lengthening as such. Now, this has been looked into that the amount of length which you achieve is maximum at the initial instrumentation at the index surgery. About 40% of the length is gained there. Subsequently, you get about 36% of length during the growth-friendly period, and you get some increase in length even at the time of final fusion. And this meta-analysis looked into different types of growing devices. I won't go into the details, as Bhavuk guided not to go into the details, but this shows that there's not much of a difference in the various growth devices that are available, except Vector, which the growth is much less than the conventional growth rods or the magnetic growth rod or Sheila as such. The new kid on the block is the anterior vertebral body tethering, the AVBT. And who else better to talk about than Peter Newton, who is here with us. So I wouldn't, and I don't have much experience in this. The basic concept is that you do not remove the disc or the end plates in this anterior approach. You put the vertebral screws and put a strong cable there and allow the growth to occur on the concave side, whereas it is compressed on the convex side, which acts as a tether. And good results have been shown. As I said, these are not my pictures. I don't have experience in this. And I guess Dr. Pete Newcomb can talk more about this. He even does it all thoracoscopically. And as I said, such long-term results are still awaited, but a good promising procedure as such. So that brings us to our case. Now, this is a 5-year-old syndromic child, double major curve, had a tethered cord, which was a phylum terminal release done about a year back. Premenarchal, triradiates not fused, Viscer grade 2. So what does one do? Initially, you try to, as Suken rightly pointed out in these small kids, you try to buy time, take them on to a more age group which is older and more amenable to surgery, and that is around 6 to 8 years of age, and that's what we did. She was about 8 years old, and she progressed, and the double curve progressed to 87 to 80 degrees. And the child was still quite small, so even at 8 years old, we decided to put her on a magnetic growth rod, which she could afford, and the growth rod spanned the entire spine, right, starting from T2 to almost L4, L5 as such. We were able to straighten her out, get the trunk out of the pelvis as such, and did OPD distraction. We tend to distract every 8 weeks interval, 3 to 5 millimeter distraction every 8 weeks, and we carried her through. And at 11 years of age, we then decided to do a final fusion. The inferior screws were getting pulled out. So we removed the magnetic rod, put in more anchors, and corrected her and fused her as such. As you can see, there's some amount of flat back still remain, but you can address it when you're doing a final fusion by doing adequate multiple osteotomy as such. Patient was very, very happy, and she's looking very, very straight. And here she was, what she was at 8 years old. You can see she had knee deformities as such, which was corrected by pediatric surgeon. And this is now at 15 years age. So from 8 years of age, she's now 15 years of age. And as you can see, she had her growth potentials and just physiology well sort of under control. So initiate treatment with casting or bracing, as Suken said, and by time, then around 6 years of age, try to bring in or 8 years of age if you can, bring your growth-friendly devices. Currently, growing rods are the currently favored ones. Magnetic rod, if affordable, then it's a good option because you don't have to do multiple distractions. Then you can go do either diffusion or observe, which the later speakers would talk about. New techniques are evolving. Convex tether has got a lot of promise. Thank you very much, Bhavuk.
Thank you, sir. There is a question from the delegates. I think there is a paper from Akash Agrawal and Ala Ahmed regarding the active apex control, which is a modification of Shila technique. What's your thoughts on that technique?
Yeah, they're doing it all from the back posteriorly, and they're looking at tethering from the back. Basically, it's a combination of Shila as well as a tether. They feel that they do a posterior instrumented tether from the back, pedicle screws, and do a fusion on the convex side, and allow the ends to grow, right? And actually, that is a good technique. I have some flavor. If you allow me to just show this, if you allow me my screen entry, can you do that, Bhavuk? Then I'll just
your screen is already there.
Oh, my screen is there. Okay, so I had hit this slide earlier. So do an exposure like the Shila, and particularly in patients with severe deformities, right? Then you can just expose. Right. Sorry, I'll just take you there. Okay, on this only. So if there's a severe deformity there, then you can just do your osteotomy there, and in the ends, then you apply the Shila principles, right? So do an osteotomy and a short fixation, but at the ends leave the ends open and allow the growth to happen. You see, and here because you do Wilsey type of an approach, the central spinous processes are not touched, so you do not fuse it. And on the top, you have the space to and allow it to grow, and then it grows, and your deformity is kept under control at the apex, and then that is how it works. And this patient, then, if you can see that was a deformity, and this over a 3-year-old period, and you can see because of the Sheila principle, you can have still some growth and hold it there. So these are the options which you can develop, you can sort of modify and put into practice.
Fully agree with you, sir.
The audience, can I put them to Dr. Jayaswal?
Yeah.
Yeah. Sir, one of the questions is that almost all the X-rays that you have shown at the final fusion show that the curve at the end is hypokyphotic, or there is a sort of a flat back there. Can we do anything during the final fusion or should we do?
Yeah, I did say that because that is one of the big drawbacks with these distractions, especially when you're spanning the entire curve, right from T2 to say L5, and you're distracting it, obviously will cause a flat back. Even if you have the lateral connectors, and even if you have the molded, bend in the rods, more so in a magnetic rod. And I did say that you did develop a flat back. So in your final correction, when you're doing it, final fusion when you're doing it, you can or add on an osteotomy there to get your lateral profile improved.
Right. Sir, also the second question from the audience
but
is...
during distraction, it is very difficult to sort of bypass or get rid of your flat back. That's a major disadvantage.
The second question is the magnetic growing rod. We are now reading a lot more about complications of magnetic growing rod coming through. What is your opinion on them in the current situation?
Yeah, there are two issues in magnetic growing rod, and I think Dr. Peter Newton will touch upon it. One is that in a conventional growing rod, in a traditional growing rod, you need not go in and fuse all the time, right? Definitive fusion is not necessary in 40-50% of your cases because spontaneous fusion occurs in the system itself. So, but in magnetic rods, people who have been revising magnetic rods have seen that there's a metallosis occurring, right? So there is a big concern that metallosis may cause problem later on. So by and large, many of them, in fact, most of the magnetic rods are being sort of put into final fusion. So that is one point. The other complication which occurs due to the magnet there is sometimes the magnet may not would fail to distract. We've had about 3 cases out of, say, about 20 odd cases where the magnets did not distract. And the reason for that, sometimes in an obese patient, when there's a lot of space between the skin and the magnet, then your magnet distractor is not powerful enough to distract the magnet. In which case you've got to open up and do other modification. Or the pins in which allows the magnet to sort of distract, sometimes that get sort of locked, and then there's a problem, then you got to open it. But if you have a problem then you can easily convert, and usually it is one side of the rod which fails to expand. You can go in and take the magnetic rod out and use a conventional growth rod on that side. So you can work around that. But yes, some problems do occur. It's not all honky-dory.
And so the problem, again, from the audience is the problems of proximal junctional kyphosis in patients where you're doing distract. Is it more common than in adolescent scolies? Is this a bigger problem in these growing children?
My experience is that if you go and use your proximal anchors at 2-3, which majority of the time you use, you will not get a proximal junctional kyphosis. I have not had problem either with magnetic rod or with conventional rods. But if you stop your proximal anchors at, say, mid-thoracic region, then there are a lot of chances of your junctional failure on top and side. But majority of my cases, I anchor at 2 or 3. I don't anchor at 4 or 5 or 6 or 7. Then the chances of failure is much more.
Right. Thank you, sir. Just I know that Dr. Jwalant Mehta has been doing a lot of magnetic growth rods, and I think he's publishing a paper on the subject. Some tips on magnetic growth rods and what are your experiences, Jwalant, over here?
So a couple of things. One is that, yes, as both Suken and Dr. Jayaswal have said, that there are some patients that we find it difficult to do our distractions. The pin fractures, the size of the patient may be a problem. But very consistently, we see metallosis. So I have a tendency to do a final fusion and remove the growing rods in all the patients, at which time we have the opportunity of doing a bit more. The return to the return to theater rates after a final fusion in big curves that you've had to do osteotomies, etc., is much higher. So I think that's really important. The other thing is that just wanted to mention that even with the traditional growing rods, when we do our distractions, we do them in spinal cord monitoring, and we've had a big series from the growing spine study group where we've looked at all our patients, and we had a few with post-operative neurologic deficit. So now, as a rule, we do all our distractions of our GA growing rods patients under with spinal cord monitoring. Not so much, you don't need that with magic rods, but with traditional growing rods under GA.
In fact, if I can add, when you're doing a conventional growth rod distraction, all the cases have to be done under spinal cord monitoring, because you're doing a distraction, so distracting the spine, and against force, then you need to monitor them. All of our distractions are done under spinal cord monitoring.
Thank you, everyone. Now we move to the surgical technique. Dr. Dhawale, Dr. Arjun Dhawale will speak upon the surgical technique. Dr. Jayaswal, can you unshare your screen?
Yeah, okay.
So hi, good evening. I'd like to thank the ASSI for this opportunity. So Isaac Newton had once said that if I can see further, it is by standing on the shoulders of giants. And this talk would be incomplete, without me acknowledging all the people who have sort of mentored me, supported me, my colleagues, my seniors, and of course my residents. So this is a case of a 3-year-old child, with a neurofibromatosis, and there's a kyphosis and a severe scoliosis. This is the clinical picture with traction. That's the X-ray. There's a large thoracic curve, 100 degrees in magnitude. This child was actually referred by one of our former fellows. This is the significant kyphosis and the curve angle of 100 degrees. That is the traction X-ray showing some correction. Now I was contemplating what to do here. I got an MRI done, which was normal. And I was thinking whether I can cast this patient. I've trained with Dr. Shah, and it was definitely one of the things I think of doing first. But the problem here was it was a little proximal, the curve. It was a sort of little proximal apex. So it becomes difficult. So I got a second opinion from my colleague, Dr. Nene, and he agreed that we need to think of doing a growing rod here. This is the planning which is being done on the Osiris or the Horos software. I always do a CT scan for the patients with NF because one needs to see the pedicles. One also needs to look for the ribs, and one needs to, sort of look for dural ectasias, etc. So that is the preoperative planning, So it's like a poor man's navigation, so that one can plan one's screws trajectories and, keep alternative anchors available. And you can see there that I'm sort of marking out the pedicle in the proximal thoracic spine. That is the positioning of the patient. We always get a baseline, neuromonitoring in supine and then in prone. That's the implant trolley. One needs to sort of have everything available. One should have low profile screws and, both the types of distractors, the lateral connectors. The trolley should be complete, with everything, all the instruments. The scrub tech and the implant person do contribute. That's the marking of the level. I've marked out the 11 there, taken a small incision after, radiologically confirming. Expose the lower two levels. I tend to use the cautery as I've been trained that way. And this is only unilateral exposure because we're doing only a single growth rod, because the child is only 11 kgs. I don't see myself being able to get 2 rods across. So that's making the entry point. I usually do all the screws freehand, but in an early onset case like this, because the child is so small, I will do a C-arm confirmation before I put the screw in, because you don't have too many chances, and the pedicles are also small and dysplastic. Sounding the pedicle, measuring it, and then tapping. So here, this is a 4 mm system. All right, this is so after tapping, we sound again, and then cannulate the pedicle. So I usually expose both the levels together. So one needs to be very mindful of the placement. If one is planning to use pedicle screws, one needs to be very cautious and careful. And I always do an MEP check after doing each screw, just to be sure that everything is good. This is C-arm check, showing me that the first screw is well placed. My entry point for the second screw needs to be a little proximal to where that entry owl is. And then, of course, after tapping, and the similar procedure is done. You have to sort of feel, a good walls on all sides, anteriorly and medially, and superiorly and inferiorly. So remember, this is a very low profile implant we're using here because we don't want skin problems. It's a small child. So again, a radiological confirmation. Then we move to the proximal incision. And again, a similar exposure. Now, one has to be extremely careful with the proximal thoracic spine in a patient, who's so small and, with dysplastic pedicles. So one should be mindful, continuously monitor the MEPs, when one is instrumenting here, and always keep alternative anchors available here. So again, I'm tapping here. Now I tend to keep the proximal, if I'm going to cannulate the most proximal level, I will tend to be a little lateral. I won't medialize too much, just in case there is a failure. I don't want the screw backing and sort of through the canal and hitting the cord. I believe this is an underreported complication, and so one needs to be careful. Okay, and then that's the screw, which is because the most proximal screw is the one which will fail first. So if you can note, I'm not medializing as much as I would otherwise. Okay, but I had a good hold here. Now this is the D3 level. Again, similar sort of steps. Now, if I face difficulty, then I would not keep trying. I would sort of look at using a hook. I would not sort of keep struggling. But I knew preoperatively that this was a sort of possibility to get it right. Again, keep checking the MEPs, when you're doing the instrumentation. So taking the right measurement and then passing the screw. So that's the confirmation radiologically that, both the screws are acceptable. Now this is the lateral sort of domino, and that's the longitudinal domino, where you can sort of, the problem with this one is it gives you less length of the rod. These are the hooks, the pedicle, and that's the rib hooks, right? Now you take a flexible rod, you sort of bend it to the degree you want it. And of course, to sort of understand your length, to take 2 rods. This is a titanium 4 mm rod, basically. And now I'm sort of making a subcutaneous tunnel. So you can see that I'm going submuscular. You don't want to be subcutaneous because you'll have implant issues, and you don't want to go too deep because you'll create an autofusion. So you just want to be in the right plane, go sort of slowly, and then expand the track carefully. Now you have to sort of pre-bend the rod. So what I prefer to do is sort of make the construct outside itself, pre-bend both the rods, just to sort of factor in the kyphosis and the a little bit of the coronal deformity. So you can see there that that's approximately what I've decided I need. And then I'm kind of tunneling the rods. Okay, you can see that there is kyphosis which is incorporated proximally. you don't want to stress the implant basically. All right. And the first procedure is you are getting correction just with the anesthesia and the positioning, etc. So you don't want to distract. I will not distract on these anchors in this first surgery, the index surgery that will be done after 6 months. So that's the the knee is going in, and just enough to get a little kyphosis correction here, but without too much stress. Okay, because I'm always worried about a failure. So you can see there's not too much stress. All right, not too much stress on the implants. And then that's the final tightening done. And that's the closure, always a subcuticular closure. That's what the AP X-ray looks like. That's what the lateral, you don't want to bend around the area where you're going to do the lengthening, basically. You just want to bend around that's the post-operative picture. You can see that this is a case I've just done like 2 weeks back. So you can see the sutures still there. Okay, there is some correction. But remember what I said about the proximal sort of curve. It's a little too proximal to do. So I was contemplating whether I had any other options available. The kyphosis again, which is a risk factor for a failure here. But the inability to sort of put the other side rod, and I've actually chosen this case because it is a case where I can get the opinions of all the senior faculty as to how they would manage this patient subsequently. I would like to acknowledge, my fellows who helped me with this case, the anesthesiologists, the neuromonitoring team, scrub tech, and the pediatric team, because I believe all these cases are actually a team effort, and it is everyone's equal contribution which leads to success or failure. So I don't think it's just the surgeon. I think it's the entire team which has to work together. And I truly appreciate all my fellows and residents for all the hard work they put in for all these patients.
Thank you, Arjun.
That's the lateral. I'll just show you the lateral and the last X-ray. So that's the last X-ray there. Thank you very much.
Thank you, Arjun. Since we have a very high incidence of unplanned returns in these growth-friendly techniques, and in view of lack of time, we will just have the one tip from each faculty members to how to prevent, and what are their one single most important tip which they can give, technical tip. So let's start with Dr. Jwalant.
So what I would say is we've got a fair few number of neurofibromatosis. And a single rod, the chances of a rod fracture is very high, up to about 20-25%. If you have 2 rod constructs, even in a kid like this, the way you've done your surgery doesn't look like the rods are very prominent. So I think that he would have tolerated a second rod. If he doesn't tolerate it now, wait for a while, and then the next time you change anything, it would be worth going in for 2 rods.
Yes.
And I think that if you want to do a magic rod, that's very bulky. But in a traditional growing rod, you can really go for a two rods. I think the numbers drop from something like 22% with a single rod to 4 or 5% in the double rod with for the rod fracture. So I think that's the one thing I would do.
So I am going to put this child in a brace, and the plan is to sort of distract once, and then maybe when the weight goes up to 15, put in a dual rod. And then maybe stretch out, till the child is 6, etc., and then maybe convert later to a fusion, because I don't believe that in NF one can continue this way for a very, very long time. So, but of course, I'd like everyone's inputs here.
Yeah, I would say my biggest tip would be try and get it right the first time, meaning you get your best correction at the time of the initial implantation, and you're lucky if you can keep up growing the spine and controlling deformity at the same time. What you'll see in most of the studies is your initial correction is the best decrease in the deformity, and then you're just trying to grow. So however you want to do that, halo gravity traction, intraoperative traction, and then kyphosis is another bad actor in this problem. And you want to try and correct the kyphosis as much as possible, or at least accommodate the kyphosis. The proper rod contouring at the top is very important. We talked about the upper instrumented vertebra, but also rod contouring is important. And if you don't think that 4 anchors is enough, you can do 6. I would try sublaminar bands in addition to screws to sort of back up that fixation, because as you start to lose fixation at the top, you're going to have to keep revising that.
Professor Rajashekharan, you are muted, sir.
Bhavuk, just like to echo whatever Suken has said, because I think the difference in the complication rate between a single rod, whatever rod it is, magic rod or a traditional rod, is huge between a single rod and a double rod. So we would take care that we would always try to have 2 rods instead of 1. Our initial results with 1 rod was not so good. And the law of diminishing returns work so much on this. So your best gain is in your first surgery. So you need to plan your first surgery really very well.
So Jayaswal?
Yeah, one of the things which we learned over the years is to use the the screw size as such. So we are able to use now, even one is of course carry them. This child is a slightly younger child, so if you can have another year or year and a half added to it, your results dramatically go up. So try to take it to about 6 years of age. And then your screws which you use, I have given up using the 4.5. I use 5mm screws on top and 5.5mm screws in the bottom. Even if the pedicle is small, they are cartilaginous. So you're able to expand the pedicles as such when you're using, and your implant failure rate really comes down if you use a good size screw. As earlier when we used to use 4mm screws and 4.5 in the lower spine, and the 4.5 rod system, the breakage was very, very high. Or if you really have to use a very thinner rod, then after a couple of distractions, then you can switch over to the conventional 5mm rod system. So that will cut down on your implant failure a lot. And as Suken said, add an additional anchor on top to supplement your things and to sort of able to be able to correct your deformity, even the kyphosis, if it is particularly, if it is not a severely congenital kyphosis, you'll be able to sort of by cantilever with three screws on top, you'll be able to a great extent be able to sort of control that. And double rod is a must.
Final comments from Dr. Peter Newton, and also about the role of transverse connector at the top, and also the use of two-stage growth rod when you apply screws and you leave it as such so that the bone can form around the screws. Dr. Peter Newton.
Thank you. I guess I would say that I would, even if I could only fit one rod in, I would still do a fusion on the other side. Having that stable foundation and starting to build some bone at the ends of the construct will at least give you some more to work with when you come back for the revision when this inevitably fails if you start at such a young age. So I actually prefer hooks proximally for most cases to begin with in a very small patient with a lot of bone graft around the fusion. I can move that back to screws later when things are more robust and the child's a little bit bigger. But I agree with the concept of at least 4 points of fixation, and a double rod for sure helps immensely. Even if you can only get one rod in, having that foundation proximally with 4 points of fixation and a cross-link infusion, even if you can only get a single rod, I think helps your foundational stability. So I like bilateral proximal distal foundations, even if I can't get more than one rod in. I guess is where I would stay with that very small patient.
And what's your preferred, the direction of the hooks? You direct them away from the construct, or you use a claw construct?
I still prefer a claw construct, particularly if there's any bit of kyphosis. It's going all uphill. With upgoing hooks, I think is problematic. So claw fixation, and I was taught by Dr. Akbarnia that those should be laminar constructs rather than pedicle transverse process. And I guess I still use that to the most part. Obviously, putting a laminar hook down going really risks the interspinous ligament and creation or destabilization that might provoke some of that junctional kyphosis. So I think you have to be cognizant of that as well. But that proximal foundation in the setting of kyphosis is very problematic, and throw neurofibromatosis into the mix with really diminutive pedicles, and I think it's really a challenge. So I would emphasize the concept of really trying to delay this using some. I've even got kids that I've got in traction just through a brace to buy another year or two. So using traction to help resist that kyphosis, treat the kyphosis, maintain some flexibility of the curve, and let the kid get bigger, I think is also a strategy that can be utilized.
Thank you. Now we move to the last talk of the session. Dr. Peter Newton, your talk about the graduation protocols.
All right. Well, great. Thanks again for the opportunity to join you all. It is still a bit early in the morning here, but I'm hanging in with you. This question about what to do when things are finished or so-called finished, I think is really a great topic to cover, and I'll at least try to take you through my thoughts on how this how my thinking works on this. So we've got our lengthening done, and the question is now what? And the basic options are to leave it alone, just let it sit, remove it, or revise it to a so-called final fusion. There's been, I think, a fair bit of evolution in the thinking of this, certainly over the last 10 years. And maybe it was spurred a little bit by Pat Cahill's article that suggested that 8 of 9 growing rod patients had, quote, autofusion. And so this idea that the spine is already fused is, I think, been promoted, although I must say I don't think they're all necessarily completely fused. In 2013, Jack Flynn and the Growing Spine Study Group coined this term graduates. And in their series, that initial series, 86% of their, quote, graduates had undergone re-instrumentation and fusion. So the trend at the time was to do fusion in all of these patients. But that, I think, began to change about 5 years ago when people started to report that maybe just observation is a viable option. And both the Children's Spine Study Group and the Growing Spine Study Group presented papers suggesting that you could just leave your growing rods in place and observe the patient. Now, the other option that we mentioned was removal. And Muharrem, I think, did a nice, presented a series of cases in which the growing rods were removed at the time, thinking that they were, quote, spontaneously fused, or that they had motion that could just be maintained. Either way, that didn't work very well, and 9 of the 10 patients progressed. So that's the one definitive statement I think I can make, is that taking the implants out and walking away is a bad idea. So you've got to either pick observation with the rods in place or revise and fuse. It's certainly been my impression that this trend towards observation has been gaining some traction, and there's some rationale for that, and some of the literature suggesting. The biggest reason, I think, is that this, quote, final fusion is not an easy operation. It's the dissection is a mess because it's all been scarred up, and the rods were lateral and usually placed lateral without midline dissection, and so preserving that whole muscle envelope is difficult. The curves tend to be stiff. There is often some component of autofusion, although, again, I think kind of a universal fusion throughout is unlikely. There's frequently junctional problems, and the correction is tough and often limited. So this idea that growth-friendly surgery is ultimately friendly doesn't seem to be the case when you try to go back for a final fusion. And in this patient, there was a substantial proximal junctional kyphosis that we addressed with during the final fusion. But again, it's a difficult operation, and there are frequently 3-column osteotomies involved in if there is substantial deformity, which, as was mentioned previously, is often in the sagittal plane. either with a flat back distally or a proximal junctional kyphosis proximally. So you can skip the final fusion, I think, in some patients, and those frail populations and kids with relatively low demands at high risk for complication, I think it's very easy to just say, hey, we're going to leave this stuff alone and just sort of see if we can make it. Matt Holansky published a series in the SMA population, and the OI population is another area where this strategy has been taken for sure. But some of these are going to eventually fail. And I think you just have to decide whether you want to deal with a failure on an urgent basis when it becomes symptomatic, or whether you want to do it on a somewhat elective basis. And that is really, I think, sometimes a tough conversation, and one you just have to have with the family to see where they land on all this. It happens in Shillas as well, and I think we're in that same sort of scenario of trying to decide if you've made it through all this sort of saga and even got the rods fixed, but you're still going to end up with some of these breaking, and then your so-called final fusion is no longer elective because it's hurting or the rods are becoming prominent, and you've got to sort of take it on at a time when you might not have wanted to. So, but even still, I think that many of these will still be okay with observation, but just be ready to go ahead. There is a more recent paper looking at the greater than 5-year follow-up of patients from the pediatric spine study group, now the combination of the children's spine and growing spine study groups. And the quote from that paper: patients who underwent spinal fusion as a definitive treatment strategy were more likely to undergo revision surgery, 27%, than those patients that had their growth-friendly implants maintained, only 11%. And I think that this is, it can be both some truth in the fact that this is what the numbers are, but it's also, there's some bias here into who actually undergoes revision surgery versus is going to have their implants maintained. Typically, those undergoing revision are those who have residual deformity, and those may be more challenging cases, may require osteotomy, and will have a higher revision rate. So in summary, I guess I would say that for the frail, low demand patient, I think it's fine to observe with the implants in place. Those who are more robust with more normal demands, you really have a choice of observing versus doing that final fusion, realizing that you may be doing a final fusion, either quote final fusion either way, but you may be doing it on an urgent basis if you just observe, more than an elective basis if you kind of pick when you want to do it. It's convenient. If there's residual deformity that's substantial, it almost always requires some sort of revision and final fusion, and again, frequently in combination with some sort of an osteotomy. And if you've got magic rods in place, at least the recommendation from the FDA and from the company is that those have got to be removed and have a final fusion. And that was mentioned earlier in the webinar. I must say, I think that that's likely the case. These magnets being in place over the long haul, we don't really have good understanding. The failure of the mechanism and pistoning has certainly created some very substantial wear debris issues. Now, whether or not that will be fixed in newer versions and with better seals at the motor rod junction, all are, I guess, remain to be seen. But I guess I would say currently I'm thinking that most magic rods would come out eventually and get revised. But I guess we'll have to wait and see. I would like to emphasize that in this population, the decisions that we're talking about and that have been discussed so nicely in this webinar are really very, very critical. And I think the decision-making in this population is more important than really any of the decisions that we make in other populations. There's such a lasting effect. When you begin growing rod treatment, you're committing this patient to years of operative intervention. And as suggested, delaying as long as possible, I really think should be the mainstay of what we do. And that can be done with casting, as Suken so nicely presented, but it can also be done with forms of traction, either with a halo or without. And remember, the younger the patient when you begin, the greater the importance of getting it right. So also that point about when you do that first surgical intervention, doing it as accurately and with the best decision-making possible is critical. So again, when possible delay, I would much rather have a big curve like this that's never been touched than one that's a revision of some sort of so-called growth-friendly technology, no matter what it is. So much easier to manage if it's never been dealt with before. So my tendency is to let these curves get pretty large and then just try to go after them all at once. And the question about how late can we still do casting, I've got some 9-year-olds that I've casted just to try to buy another couple years so that we can do a single definitive fusion down the road. So I can either stop there for some question or comment or move ahead with a case.
I think you can move ahead.
Fair enough. This is a case of lots of decisions to be made. The boy is a 2-year-old. He's got increasing deformity. He's got a condition called lateral meningocele syndrome, which is a genetic condition associated with severe form of dural ectasia. Common spinal deformity is present, normal intelligence, and this is a really sweet kid I've had a long relationship with. He walks, doesn't have any pain. He's got a fairly substantial deformity even early on, and we started him in a cast and a brace when he was little, and by age 4, his kyphosis had become much more substantial, and was we were, at least at the time, feeling this was not braceable any longer, and we moved ahead with growing rod treatment. Today, I might have tried a little longer, to be quite honest with you. Here's just some imaging of his dural ectasia. So just massive dural ectasia extending out anteriorly and scalloping of the vertebral bodies. Posterior elements were absolutely a mess. But we put growing rods in. You can see we're able to get double growing rods in, and the foundations proximally and distally with cross connectors, and that fusion at the top and the bottom to try to maintain that correction. This went okay for a bit. There was some revisions along the way, but some length gained. But you can see over time that this construct is almost pulling away from the anterior vertebral bodies as the pedicles elongate and these dural ectasia kind of expand out the neuroforamina. And so he's getting a progressive flat back, but you can also see that the anatomy that we have to work with is pretty limited. So he eventually got revised to the pelvis, and this went for a bit, but he started having greater loss of lordosis and more coronal imbalance. It got revised again with the addition of an osteotomy through the lumbar spine to try to restore some of that lordosis, and we fused the bottom half and put sort of a proximally based Schilla construct in. That kind of got infected over time, and now we've got him to age 14. But you can see largely with implant removal, he's gotten much more deformity proximally. So again, this concept that you can just remove implants is not one that we should participate in. So here's just some more of imaging of what he looks like at that point. So he clearly has some autofusion, but of course he's got areas which are not fused, which are resulting in that continued progression of his deformity. So don't assume that the deformity will be, that things will have fused even after all this length of time. So here he is again. He's still got this limited anatomy to work with and massive canal. So I did use some halo traction on this boy to try to get some correction of that kyphosis. We got his body, about half of his body weight. Helped a little bit, but he was still having trouble. So we contemplated other options at this point as listed, and went back in to try to see if we could get fixation and correction. We ultimately did do pedicle subtraction through the bottom of his kyphosis there, and used some bands or some cables to get some fixation, and moved up into a cervical spine where we had a little more normal anatomy to get some fixation, and got overall some reasonable alignment. I would say that these some sort of a cable with a connector that you can slide up and down can give you fixation that isn't as good as a pedicle screw, but is better than a hook. And if you're doing a 3-column osteotomy, can give you enough stability to get away with that. Get a halo afterwards. We managed to sneak through all that without getting any CSF. So, I mean, overall, I think we got some improvement. We've had quite a saga throughout his life. Unfortunately, the story isn't finished there. He was up walking, doing well in high school, but represented about 2 years later with progressive weakness, and his dural ectasia and arachnoid cysts have eventually just caused nearly complete atrophy of his spinal cord, and he's now a full-time wheelchair user, unable to ambulate due to progressive loss of function in his lower extremities due to these just terrible arachnoid cysts compressing his cord. Despite decompression, and he's not been able to return to walking. So kind of a sad ending to that story, but I think there are a lot of lessons to learn in cases that you start and have now, I don't know, that boy's probably got 15 years of follow-up from the time that we started with him, and so maybe starting a little too early, but I don't know, clearly some lessons in there. Don't implant removal is not going to be successful, but sometimes you have to due to infection, and the osteotomies that are required later are often tough to accomplish, even in cases like that.
Thank you, Dr. Newton. Just a quick question. Dr. Jayaswal would agree that we have seen some cases crankshafting at the distal level when we are using these growth-friendly implants, what we call as the lowering of the apex.
Yeah.
You're to deal with them, and any risk factors by which we can identify that these curves they're at risk?
Well, it's a great question. I would say that in general, I try very hard not to extend the growing rod or any sort of growth-sparing construct into the area of the spine that's not abnormal. But the shorter you make the construct, the more likely it is to add on or do some form of, whether you want to call it crankshafting or adding on. And you end up having to extend that final fusion more distal than where you started. And so it always makes me nervous to do an instrumentation to L4, knowing that it might have to extend to L5. I really want to sort of keep the eventual fusion levels at L4. So I don't know. I liked our last case, the previous case presentation in that neurofibromatosis patient, where we at least kept it in the thoracic spine, knowing that might still give us some troubles by having it be relatively short. I still would prefer that over having a very long instrumentation. So Arjun, I think that was a good strategy to try to keep that short. But again, we're putting ourselves at risk for junctional problems the shorter we go. So I don't know. It's a tough dilemma to try to figure out whether to instrument long and sacrifice all those levels. And we say we're putting in growth-friendly stuff across all those levels, but we know that the spine doesn't grow normally in all those levels, even after we instrument. So I really, strive to keep whatever I'm going to do as short as possible as well. And then I just show you a case that's done from like C6 to the pelvis.
Dr. Gautam, do we have any questions from the delegates or?
They were bamboozled by Dr. Newton's lecture. I think the case was very, very difficult. I think one of those very. Yes, Dr. Jayaswal, you have a question. Please go ahead.
Yeah, I have a couple of questions from taking advantage of a presence of Peter Newton here. Great case, but my concern is the patient landed up with a paraplegia. I mean, in spite of all that you did and out of the hat thinking, the great management. How does one explain to the relatives and to your colleagues that actually the paraparesis or the paraplegia happened due to the dural cyst or whatever, and not because of the implants and surgery? And that becomes a big problem. How do you manage such things?
Yeah, well, that's a great question. I mean, the thing that was, I guess, most convincing to me that this was due to the arachnoid cyst was that his paraplegia's weakness didn't develop until several years after his final correction, and that the imaging just demonstrates this wispy little cord which he's had for a long time. I mean, it's not like he's had a normal spinal cord, but this case was actually the imaging was sent around to a lot of places, and this is just one of the problems that develops unfortunately in this population. And I think, I don't know if you've all seen arachnoid cysts that go bad over very extensive periods, that even when they're decompressed don't seem to respond. But I ended up in this boy doing a big laminectomy through that prior area of fusion to get our neurosurgeons access to do that arachnoid cyst decompression. But he didn't really make much progress, and he was looked at a number of centers around the United States to try to see if there was some way to preserve his spinal cord function. In the end, the neurosurgical colleagues didn't think there was much else to do, unfortunately.
In India, I will get lynched. The surgeon will get lynched for that in India. So,
well, fortunately for us, that's this is a family that's very, very clearly understood the pathology that this boy had, and fortunately has a good friend who is a chair of neurosurgery at a prominent university in the United States, who could give him advice and tell him, listen. And the dad's actually an attorney, but he's just they understand what their child's condition involves and how he was born, and have been very good proponents for trying to understand this condition, actually.
Yeah, one last take advantage of your being present here. What is your take and your honest take on anterior vertebral column tetherings?
We're going to switch topics.
Anyway, because you're here, do you think it's
no problem.
It is the future? Do you think it's going to work, especially in EOS, in the elderly or in the more advanced aged EOS near adolescent? Yes, it can work. But in an EOS, does it work? I mean, I'm just asking you on that.
Well, I think for the I guess I would say that I think tethering has a role. I do think it will be successful. I think we'll work through the challenges that exist right now, which are largely around the prediction of the effect of the tether and the durability of the implant. Those are the two problems right now. We have a very difficult time predicting how much correction we will get over time, and then sometimes the implant doesn't last very long. So, but I think those are relatively solvable problems, some by us getting smarter and some by our implant folks doing better design work. Your question about early onset scoliosis, I think, is an interesting one. Current implants are just too big to use in very small kids. And obviously the growth potential in a very young patient is so great that how to control this implant from creating overcorrection is a challenge. But again, we're talking about trying to. I would not use this implant in a 5 or 6 year old patient, with a 40 or 50 degree curve, and that will clearly cause troubles. I've got plenty of troubles doing that in 9 and 10 year olds. So there might be a role for some of these 9, 10 year old that are meet the definition of early onset scoliosis. Have used 10 as the definition, but I don't think it's going to be the mainstay of treatment for early onset scoliosis that we're talking about here. The tough ones are not going to be fixed by this problem.
Suken, your take on tethers?
Yeah, I mean, I agree with that. you know, you can't forget about anterior fusion. I know Peter's got a couple of cases where he did limited anterior fusion on early onset scoliosis and thought that that might be the first stage of another operation, but a couple of cases turned out well. So we have to keep thinking about anterior surgery when appropriate. But tether has too many unsolved questions to be an answer for EOS.
Yeah, it's interesting you mentioned that, Suken. I was actually, I was close to suggesting it for Arjun's case. I think you could have potentially gone T8 to T12 with an anterior fusion. And I've done that for a number of neurofibromatosis kids, not when the curve is quite as big as you had, unfortunately. But if I'd gotten to that one a touch earlier, I would have done that with an anterior fusion, anterior instrumented fusion, and tried to buy, you know, same 4 or 5 years out of it before you have to go back and do the definitive fusion. I think that's a good strategy that can be utilized.
No, why would you fuse then? If you're going anterior, use a strong tether there and buy your time and then go posteriorly and then use your fusion, you know, if you can take it there.
Well, I mean, I guess, I mean, again, I don't think we've got implants that fit in that size patient right now. And I don't think we've got a durable implant that will last 4 or 5 years either. So the implant failures are, I don't know if I've got anybody that after 4 years doesn't have a broken implant. I think they all fail. It's just a matter of how quickly. The earliest ones kind of go at around 18 months, which is clearly too early. And I don't know, 2.5, 3, 4 years, pretty much everyone's got a broken tether. So maybe only at one level, and maybe at a level it doesn't matter, and maybe they're done growing now, so it's irrelevant. But if you're trying to use this in someone who's not growing, I don't think that has a role at all. Although there's obviously folks who think that's the case. That makes no sense to me at all.
How can I ask a question to Suken and Peter? In these complex cases, malignant curves and neurofibromatosis, syndromic curves, what is the earliest stage that you think of a definitive fusion? Sometimes they are around 8. We think they are too early, but the pedicles are becoming narrower. And in neurofibromatosis, you leave them for some more years, you see the pedicles becoming thinner and thinner and the dural ectasia becoming more. So then you feel you're lost and burnt a bridge.
Yeah. I mean, I don't necessarily pin it on an age. We have other better ways of looking at skeletal age assessment, like the hand X-ray and sending them to their endocrinology associates and seeing, for instance, how much more Prader-Willi kid will grow. There are certain syndromes like SMA and maybe perhaps really severe, frail children with spastic cerebral palsy that an early fusion is the best answer. If you're looking back at that equation of maintaining quality of life, they don't need to be extremely tall. Maybe being smaller is going to be a little bit better for facilitation of care long-term by their parents. So I think an early fusion is still a decent option, provided they are going to be small. They're going to be a small person. So we don't have normative growth values for CP or skeletal dysplasia or OI, for instance, but we do early fusions on all of those patients. And I think when you've burned some bridges and you don't have another solution, try and gain as much spinal length as possible when you do that fusion would be the key.
And in these neurofibromatosis and other syndromic patients, how much do they follow the usual law of spinal growth? I mean, you may look at the upper humeral epiphysis or other skeletal markers, but how much do they follow these routes? Do their spine actually grow that much?
No, I don't think we have good data on that. I don't think they grow that much. And you'll also see the same thing in growing rods. When you put a growing rod in some of these NF kids and you ultimately look at how much they actually grew, it probably wasn't that much. It might make us feel better, but maybe an alternative solution would have been doing an early fusion, or as Peter suggested earlier, delay, and then do definitive fusion when they're a little bit older.
The other problems in these conditions, which Raja mentioned, small kids, say 7-year-old, and you know, the thoracic spine is also involved, the entire thoracic spine. The question to both of you: would you still do a definitive fusion, or try to buy some more time if you really can? You know, because it's okay, you can accept a small height, But the thoracic, entire thoracic involvement, if you fuse, then you're sort of playing into thoracic insufficiency. I don't know, you know.
Now, Arvind, my question was, how much do these thorax actually grow in the last, 8 to 10 years in this
exactly.
and very
Exactly.
neurofibromatosis?
So a 7-year-old neurofibromatosis with a thoracic spine involvement totally, would you fuse or you would be hesitant? You know, Suken and
Depends on case to case.
these are very gray areas.
I know. I hate generalizing in this population because I don't want people to leave here thinking that there's one treatment for everybody.
Yeah,
Try and get flexibility assessment. Try and use traction to lengthen the spine. I think our implants are better than they were in the past when McMaster would have to do a small fusion in a small chest. Now we have the ability to safely distract under monitoring and get spectacular corrections, increasing spinal length. So I hate making generalizations, but you know when you know.
Yep, I would agree. And the idea is that, Raja, you showed in your example, you can fuse a single level at any age. And if you can fuse a hemivertebra as soon as it's big enough, can you fuse 4 vertebrae when they're 5? And can you fuse 8 when they're 8? And what's the relationship between how much of the spine you can fuse at what age? And so we rarely are doing the entire spine, but so I think it's a really difficult question to answer, but I do think it's related to how much of the spine you want to fuse at what age, as well as the growth potential, as you mentioned.
So I have a patient who, a similar child, just exactly 7 years old with NF. And I basically did an anterior release, put the child in halo, and then did a posterior fusion. And that child had a malignant NF curve, like 110 degrees. It was very rigid. There was no ways it was going to respond to growth rods. I actually had the case ready, but I think because of shortage, I could actually show it in a minute if it was available. But, I actually had kept the case only for this point because I knew it would come up actually, but I'd leave it to the chair to decide. So.
Yeah, we'll have an US part 2 next time for that, Arjun.
Actually, Gautam, can I just add one thing?
You could, but US part 2, please. Because I have to pay extra money to the online platform for any more time than we can do, which I'm not prepared to do.
All right.
So with that, I would like to thank all the panelists for their immense contribution. This has been a wonderful. We missed India winning against Australia this evening, scoring 195 in the T20, but I don't think anybody will rue that because this webinar was so full of knowledge, so exciting, and so much to learn here. So I thank each and every one of you, especially Dr. Peter Newton. I didn't realize, but it is the middle of the night over there. He's been with us from 2 o'clock in the night in California to almost 5 in the morning. Thank you very much, sir. We appreciate that. Thank you, Suken. Thank you, Jwalant. And thank you, of course, all our senior local faculty and our young member, Dr. Arjun Dhawale, who presented beautiful case. And of course, thanks to Bhavuk for coordinating this webinar so beautifully. We've learned all. So thank you very much and good night.
Thank you. Bye.
Bye, Suken.
Bye.
Take care, guys. Great to see you all.
Hi, everyone.
Bye.